walked in and I had to take it quite slow. I did think if I fell and broke an ankle or wrist, I'd have many doctors to take care of me at the office. But thank you all for being here. It was a little bit of a treacherous morning, but we're going to get started. And as always, these are going to be publicly live streamed. So Andrew is going to let us know when we're ready to go live, and we'll kick off this meeting. Thanks, everybody. You can go right now, David. Executive Director of the Health Policy Commission and proud co-chair of this task force. Welcome, members of the Primary Care Task Force, to this, I think, our 7th meeting as a task force here on March 4th. Welcome. Thank you all for being here and being here in person this morning. We have a full agenda, many great discussion items for you today. But before I introduce our agenda and our topics, I first want to just offer our co-chair to provide some welcome remarks.
Yes, thank you, David, and thank you for all the task force members who are here today, especially given how difficult it was. We just said it wasn't that difficult, but it felt like it was going to be difficult. There was more like that psychological thing about like, am I going to do it? So thank you for being here. I think it's very clear that the context, both at the state level and the national level, makes it very clear that the next few years are going to be very, very busy in terms of health policy changes, health insurance changes, challenges to the current system. So I think that the work that we do has gotten even more important over the last few months. I was joking with David yesterday that each subsequent meeting, the degree of difficulty of like the particular Olympic trick that we're doing is growing. And so we expect today to be one of those times where the degree of difficulty is pretty high. So we're looking forward to a spirited but intelligent discussion.
Great. Well, we have a triple Lutz today for all of you. We're going to kick off the meeting by first sharing a little bit about the new Healthcare Affordability Working Group. We're then going to just share a few brief findings from a recent Milbank report. The bulk of our meeting is going to be spent continuing to discuss what we call statutory deliverable number 4. This, I think, will be our third full task force meeting where we've been focused on payment models. So we're going to continue to move forward on that particular discussion. And time permitting, we'll have an open discussion on deliverable number 5, which is focused on how changes to health plan design might improve access to primary care. And we'd love to hear some thoughts from the primary care task force members. But before we get into today's agenda, we do have a little bit of business to take care of, which is approval of the minutes. So just as a note, normally when we do this virtually, we have to go around and ask everyone for their each individual vote. Since we're here in person today, we can do this just by a general call of the yeas and nays. But before we do that, I first want to ask to see if there is any discussion, questions, or comments or edits on the minutes. Seeing none, I'd be happy to entertain a motion to accept the minute. Thank you. Thank you. Great. I will call for a call of the yeas to accept the minutes. Nays? Any abstentions? Thank you. Thank you, Colby. All right, great. And the minutes are accepted. Thank you. So first, just wanted to spend a moment and reflect on a really important development in our policy discussions here in Massachusetts. This actually happened on the exact same day that we held our last full task force meeting. As you may recall, we held our last full task force meeting virtually. And we ended that meeting a little bit early as some of us were then going up onto Beacon Hill to meet with the governor and to be able to be part of this really incredible announcement that she made in terms of bringing people together to launch an important effort to have some collaborative solutions on healthcare affordability. You can see here this picture from the announcement that was held on January 14th, and a quote from the governor talking about how healthcare is too difficult and too expensive for far too many people. We are taking the most comprehensive action in the country to make it faster, cheaper, and easier to get the care you need. This is a moment of urgency, and today we're bringing healthcare leaders from across healthcare, business, and labor to find every possible step we can take to lower costs and improve healthcare in Massachusetts. This is a really powerful statement from our executive, and I think also builds on a statement that she made at last year's State of the Commonwealth, which I think helped in many ways launch this particular primary care task force, where she called for reforms in primary care and the foundation of primary care, and called for an army of primary care such that every resident in the Commonwealth could have access to primary care. So this working group is launching and is charged with coming up with solutions on some of our healthcare affordability challenges. There are members of the working group who are here with us today. And the working group is being co-chaired by former Secretary Kate Walsh of Health and Human Services and Lisa Murray, who is the president of Citizens Bank of Massachusetts. This is, I think, an incredible opportunity to bring together, as the governor says, kind of a cross-section of different folks, including business, healthcare, and labor, and others, to talk about, I think, a much broader sense of proposals than even what we've been discussing here. But I just wanted to share with this task force how it has been presented to me that how important the work of this task force is, and how that as this affordability work group is coming together, that they will be looking to the recommendations that we have made and are making as foundational and fundamental to the work of the affordability work group. So this work that we have been working on for this, really almost a year now, not quite a year, is really critically important to being able to feed into this effort. I will say personally, I believe that strengthening and urgent action on primary care is fundamental to tackling our affordability problems in Massachusetts, and that's something I will continue to advocate for in my role as a member of the working group. And so we'll be bringing a lot of the conversations that we have been having into those conversations as well. We still have work to do. And let's continue to build on the momentum and urgency of our work. People are looking to this task force, not just the affordability working group, but as I think the legislative leadership is looking to our recommendations. And so let's continue the strong momentum we've had over the last year and continue to be able to feed into these important discussions. So with that, Mr. Secretary, I hope you might provide a few other remarks on the affordability working group and how that might connect to this task force.
Yes, just to emphasize what David has been talking about, which is that at the behest of the governor, EHS has convened this working group. And really the aim is to significantly and meaningfully change the landscape, particularly when it comes to the ability of the residents of Massachusetts to be able to afford healthcare premiums and to be able to actually access healthcare. And I just wanted to emphasize what David said is that both co-chairs have repeatedly said that they are not looking to reproduce the work that we're doing here in this task force, but they really will be taking the work that we have as essentially the offerings that they will consider when it comes to primary care. So I think that as opposed to it being a situation where our work here could be sort of devalued, it's actually an opportunity where our work actually is getting amplified by this work group. I'm very excited about this work. Obviously, it is very difficult to come up with agreement among things that we can do to meaningfully impact the cost curve, both at the aggregate, but also for the individual, what the individual person or family is feeling. But I think that it's either we come up with a designed, to some extent, set of solutions, or we will just be subject to various forces out there that are shaping the industry, right? There's no like status quo that's good or that's preferable. So I'm very excited about the work group, but I'm even more excited because of the work group for the work that the task force here is doing.
So happy to entertain any questions or comments from task force members on this particular topic, if anyone has any. Great. Well, seeing none, we will keep you informed as much as we can as this work continues. Great. So moving into today's agenda, before we dive into the deliverables, did want to just spend maybe 3 or 4 minutes on a new report that came out since our last meeting from the Milbank Foundation, really focused on the value in primary care and investing in primary care as a strategy to reduce the burden of chronic disease. And so this was, an interesting report and one that really did some analysis based on some Medicare claims data and some analysis over time. We have linked the report on our resources page on our website. I'm not going to go through all of the findings of the report with you today. Did want to share some of the findings here that were very specific around primary care and patients with chronic disease who had a usual source of primary care, and some correlations that the report found in terms of reductions in hospitalization and in emergency department visits and in healthcare expenditures for those patients who, both adults and children. This is specific to children on this slide, adults and children actually on this slide, who have a chronic disease, had a usual source of primary care, and observed reductions in some of these key outcomes. The findings from this report ultimately led to a series of recommendations in this report. I won't go through all of the recommendations here on this slide, but just did want to continue to highlight how the continued literature, evidence base, and expert discussion very much continues to align with the work of the Primary Care Task Force and where we have been moving over the past almost year. So you can see, just if you move down to the third recommendation here, federal and state policy should reform Medicaid funding to increase investment in primary care through enhanced reimbursement, flexible payment models, and support for practice transformation. That is very much something that Massachusetts has been working on and that we have been discussing at length at this Primary Care Task Force. Going down a little bit further, states should commit to measuring and increasing primary care spending and ensuring those dollars benefit primary care practices. I feel like we have had many conversations about that in particular. And so, again, just another place where the evidence base continues to align with our work. But just did want to maybe perhaps offer an opportunity for any reflections from task force members, in particular about how you may experience or see in your own experience the relationship and perhaps the opportunity for primary care specifically with patients with chronic disease and how that opportunity may present itself in resulting in good health outcomes. Barbara?
Thank you. So I sit on the advisory group for this national scorecard, and it was a deliberate decision to tie primary care to chronic disease so that the administration, who's talking about improving chronic disease, would say, oh, okay, let's make this link to primary care. And obviously it's huge. So I think that that's I think the report's been received quite well, and it is a no-brainer in terms of all the evidence that say, you keep people healthy, you manage their chronic disease, they'll do a better job.
Thank you. That's great context. Dr. Krishna?
Thank you. Sort of just piggybacking on what Barbara said, I would also say that one of the things we have to look at is the downstream consequences of primary care having this effect. If you look at personal bankruptcies in this world, in this country, it's mainly around healthcare debt. If you look at bad debt for hospitals and clinics, it's about overutilization of EDs and readmissions and inappropriate admissions and hospitalizations. So this has a downstream effect that's very real. It will decrease personal bad debt. It will decrease bad debt within hospitals and clinics. So I think people need to sort of expand the way they're looking at things. Primary care saves money by decreasing bad debt and decreasing things like personal bankruptcy. It has a huge impact. And these impacts on the personal patient, great. Impact on our economy, huge.
Thank you. I think that's such a powerful point, and certainly even on just this slide, when we think about, even on the first two kind of columns here, thinking about just like the follow-on knock-on impacts, you could play that out quite a degree in thinking about all of the, either economic or impacts that go for both residents, for the healthcare system, for businesses, and you can kind of follow that thread quite a ways, like one could imagine. Barbara, and then we'll come over here. Yep, or you just turned it off.
I think we have seen in nationally and in the state an increase in the number of people who are going towards concierge medicine. We're going to direct relationships with patients. And part of that is the stress of doing primary care and having the volume that we are asked to see in very short periods of time. And I think one of the things that I would love us to have as our goal is develop a system that whether you're in private practice, whether you work in a health center, or whether you're employed by one of the big academic medical centers that employ great many primary care doctors, myself included, that our goal is to provide the same kind of concierge medicine that patients who pay $10,000 extra a year to get. That is my personal goal, to make sure that my patients feel that they are getting that kind of care without paying anything extra. And that is what we should be looking at. And we need to support, that is the way we will get these numbers. We aren't going to get these numbers by just thinking that we can throw a few extra dollars at primary care and maybe eliminate 1 or 2 prior auths a day for them. We really have to think out of the box to get concierge type medicine to all of the people who live and work and are taken care of in Massachusetts. That's the way we'll get these numbers. Thank you.
Thank you very much. Dr. Anderspring?
So just looking at those numbers is a bit jarring and surprising to me. I need to look at the data more, the report more, but in all of those instances, pediatrics is pretty significant that if a child doesn't have a PCP with a chronic condition, which could be something as simple as obesity or asthma, which we know many, many children have, that they are much more likely to be hospitalized. And what that, indicates to me, and we look at it in Massachusetts, we have a workforce issue. We have, people love being pediatricians. We love what we practice. It's hard work. It's the lowest paid in medicine. It's not here for us to figure out how to do it. But at the end of the day, we're trying to care for as many children as possible. But a lot of our practices are not sustainable with the Medicaid rates, which I know is in one of the sort of recommendations. But it's really, can Medicaid go up to the Medicare rates? And I know all the internists will say, well, Medicare is not sufficient, but it's still more than what Medicaid pays. And I know the health centers are also at a disadvantage. So I just think, we look at this, more access, maybe more pay, but also it's, we're creating sort of health equity issues. or inequity because there's lack of access, and that's why they're using the emergency room. And some of the things we may or may not be meeting for our patients, that, like Dr. Spivak said, is it that they can't get in to see us for something simple and so they just go to the emergency room, or is that our hours aren't great so they just go to the emergency room because the kid has an ear infection at 7 o'clock at night? Those aren't the kids being hospitalized, I guess, but the ED visits. So I just it's heartening to see this, but I think there are some action steps we can take.
Yeah, absolutely. I see this as, an opportunity if we can unlock it, right? Dr. Mellon and Dr. Altman.
Yes, thank you. It occurs to me that the third column there about healthcare expenditures being dramatically lower for patients who have a chronic condition who had a usual source of primary care. To me, that reinforces a role that I, as a primary care physician for adults, see and feel myself playing all the time. Playing is the wrong word. I'm serving in the wrong all the time. And that is as the glue. I'm trying to think of a more elegant word. I will, but I don't have it for right now. The glue that holds the various subspecialty aspects of my complex patients' care together. So when I see a note from subspecialist, let's say an orthopedist who just injected steroids to help a joint, it's very painful. I'm delighted about that, but I'm wondering what's their sugar going to be? And does the endocrinologist who's seeing them in 2 days know that they just had that injection? Or is she going to increase all the diabetes meds because, oh my goodness, the sugar's 300 today. And then we're going to have a low sugar as the steroid absorption from the knee injection fades. That may be more clinical detail than we need here. But these are, real life situations, right? And I could talk for a really long time about and I will not, about the aspects of that glue that I provide. It is, of course, unbillable, and that's fine with me, but it's not sustainable long-term for all of us, right? So that column that shows the dramatic reduction in expenditures, I'm confident, based on my anecdotes, that there is care happening there that doesn't have a way to be billed. And the plans that I've heard talked about here, where there's some kind of funding that supports something that isn't billed as a face-to-face or telemedicine visit, feels to me like it's very supported by that right-hand column.
Yeah,
Thank you.
thank you. And I'll just to follow up on your glue analogy, we'll just go with it.
Okay.
Quarterback is the one I like.
Quarterback. To maybe to use the quarterback analogy then. Interestingly, in the study too, they do an analysis, and I won't try to even pretend to get into the details of it, but around the continuity of the primary care. So and the more continuity, the better these results are. So thinking about like if it's how long you have your quarterback for, the better your playoff team is going to be, type of a thing, right? Yeah. Okay. There you go.
Right.
Okay.
I've been.
We'll keep working on the analogies, but again, there's this concept of not just usual, but then continuous and usual, even being a more powerful relationship. Dr. Altman.
About a year ago, I was summoned to a major hospital's emergency department on a Tuesday night. I got there about 8 o'clock. My wife summoned me there because a family member was very sick. And as I arrived in the waiting room of the emergency department, I counted the people in the emergency department waiting for service and for care. And there were 85 people waiting for care. And the nurses and the front desk at the ED told us this is a standard night at the ED. And I looked around and I was tempted to start just doing rounds. And I was convinced that about 3/4 of those people, if I spent a few hours, could help them and get them home. My wife said no. So I didn't do that. And I look at these numbers that you have displayed on this slide. This is for routine primary care that we're offering right now. We can do so much better with advanced primary care. So if you take all the people with chronic illness, and by the way, that's a lot of people, and those people are spending most of the money, and you can save roughly half of the cost of healthcare, talk about a boon for the affordability working group or the primary care task force. Imagine what we could do with advanced primary care. Primary care has a triple superpower. We know the data is clear. Primary care makes people healthier. It cuts health disparities, and it does both of those things at a decreased overall cost. You get more for less. And this primary care task force has agreed to double primary care investment and go to 15% in its wisdom to address this. And I think that if we really do this and we really do this right, David, the cost growth benchmark should be a negative number.
John likes that, yeah. Any other comments or reflections? Oh, yes, Dr. Altman. Oh, sorry, I didn't see all the, yeah, thank you.
No, thank you very much, and really appreciate this conversation and always with this group and others. So I had a chance to read the report in full. I would deliberately add to their definition of chronic illness and disease. So the two of the major ones, two of the three were hypertension and diabetes, most all of which are asymptomatic. So I think we should really point to the advanced primary care that Wayne just mentioned, which is people who are going to benefit in their quality of life and costs, and are people with mental health and substance use disorders. And we need the capacity to be able to do that well in primary care, and we need to make sure that we focus on it, because if we don't deliberately focus on it, people will be left out and have been left out for centuries. So I would just please have us think about that. That sort of ties into our work group discussion of integrated behavioral health as well. So thank you for that.
So just in terms of this cost, I want to give some context because the Commonwealth Fund every year does a report on the state of healthcare or of the nation. And Massachusetts is always number one. And yet, when you look at what we are worst at potentially avoidable emergency department visits. We are worst at admissions for ambulatory care sensitive conditions. We are worst, the very worst, 50th at 30-day hospital readmissions. Wow. Data has been sitting there for at least, as long as I've been tracking this report. That is the reality. And so clearly there's so much opportunity here. And, the other thing that we're very low at compared to the rest of the nation is primary care spending as a share of total healthcare spending. So which goes arm in arm, which is what this report says. And so the only way we're going to address this affordability crisis that we're in is if we invest in primary care, because the data is there. If we take care of things before they become worse, then we could do it. So obviously there's a lot of issues and, sort of who benefits, who loses as we move towards there, which we have to have these conversations, because it clearly there is a tremendous amount of money. And when you say, Massachusetts, you hold up a mirror to us with this data, and this is who we are. These are the decisions that we have made. And if we want to do something differently, it's got to be a very intentional effort. So I'm happy to share this report with everybody, but just wanted to mention that.
Yeah. Thank you, Barbara. I've looked at that report many times, and the Commonwealth score rankings, it's a composite score and they have a bunch of different categories. Overall, we're number one in the category of kind of avoidable utilization and costs. We're 35th in the country and in some of the rankings that Barbara just mentioned. Suzanne, and then we'll come back to Renee.
Thank you. I'll be very brief because I am going to echo two of the points I was going to make around Wayne saying that there's a direct through line to the healthcare affordability work here and around the integrated behavioral health piece. And I'm just thinking this is all fantastic. And I'm thinking about where can we speak also to more of the upstream prevention around preventing some of the chronic diseases. And I know that's not just on the primary care providers, but what other systems do we need to have in place? And that might be part of advanced primary care, thinking about that, especially important in pediatrics, of like, what can we do on the prevention side of this as well? And I think it's a little harder to quantify, but just wanted to keep that in part of the conversation moving forward.
Thank you.
Okay, so let me give you a story of the healthcare dollar. I was admitting a patient into the hospital, taking a history maybe 3 months ago. And I looked and was like, oh, eustachian tube dysfunction. I said, you have eustachian tube dysfunction? And he's like, yes, I have eustachian tube dysfunction. And it was diagnosed at Mass Eye and Ear. And I was like, sorry, all the primary care docs are laughing. Eustachian tube dysfunction is basically a little congestion in your TMs. And it's treated with Afrin. This gentleman didn't have, but it's horribly painful. When I'm talking to people about eustachian tube dysfunction, it's like, does it feel like someone is like stabbing you in the ear with a screwdriver? And they're like, yes. I'm like, here's your Afrin. But that is the thing where this is someone who didn't have someone to go to and say, Dr. Critchlow, it feels like someone's stabbing me in the ear. So he went to the Mass Eye and Ear, not even a tertiary hospital, quaternary, probably the best ear hospital in this known universe, sat in a waiting room for 10 hours and got Afrin. That took up space from someone who had a tumor, okay? That's what we need to keep in mind. That took up space from someone who had a tumor. Primary care is not the enemy of specialists. We are also not the feeder of specialists. We are the partners in making sure appropriate care gets to the appropriate person at the appropriate time. And we do it at lower cost, and we decrease disparities. And I got to tell you, the other downstream sequela is those 50% fewer kids that didn't get admitted to the hospital for asthma stayed in school longer. So those are the sequela that we're looking at. Create more space for the specialists to see the people who need specialists. Create a trusting environment for the person who feels like someone's sticking a screwdriver in their ear, but they only need Afrin. And doing it at a lower cost. That's what those numbers mean.
How do we move to a system that delivers the right care at the right place at the right time?
Last part.
Yes.
Last part is, how did we get here? We got here because the two largest health systems in this state do not have family medicine residencies. Full stop. Full stop. They haven't had them. If they had family medicine residencies 20 years ago, we wouldn't be in this room. I would be outside falling down somewhere.
Laura, I'll give you the final word on this, and then we're going to move on.
Positive. I think Renee really summed up in a beautiful way why we're all here. And the story you told, I think, happens thousands of times a day. People need to have a primary care doctor and a practice that they can trust in and be seen. And we need to really invest, I think, in urgent care, in extended hours so that people stay out of emergency rooms. But we really can get back to having that relationship in a medical home. I think we really need to push that. And behavioral health, I keep on saying this needs to be an integral part of this because those folks oftentimes just get lost in the shuffle. So thank you for those words.
Thank you. This is a great conversation, and I think a great prelude to continue to just kind of like remind us and focus on like, what is this opportunity? What are we working towards in this task force? And there is just such an incredible opportunity here. So I'm going to move us now to continue our conversation on one of our legislatively mandated deliverables, which is around talking about how we might recommend changing payment. So this is, as I said in kind of our preview, I think this is now our third kind of full task force meeting where we've been talking about this. And so at this stage, what we have prepared in the next few slides is starting to move towards what a draft recommendation might look like and the component pieces of that reflecting the conversations that we've been having over the last few meetings. And so, I really want to be able to hear your comments and feedback on these slides, the text in these slides. Are we kind of hitting that right balance in terms of level of specificity? Are these are at a level of principles, of considerations? Do these reflect, the consensus that we've been talking about within this task force, so that we might begin to move towards, drafting up a recommendation that we can put up on the website and hand over to our legislative partners. So this is going to really, I think, be the next, 45 minutes of today's meeting. So on this slide, just to orient you to kind of the outline of the kind of draft deliverable here, this is very much model after how we've done the other ones. So we begin with a brief introduction. What is this issue? We have a section that is kind of a summary of the conversations that we've been having, and then getting into a section on some specific task force recommendations. In this particular case, we've bucketed them into 4 recommendations: advanced primary care model, payment model design considerations, multi-payer implementation, and then a bucket on monitoring and accountability. So I think there's a lot in the next few slides, admittedly. I think it'd be helpful for you guys to hear kind of the full scope of everything that's in here. And then we can kind of return to the beginning and kind of talk through piece by piece, because as with many of these recommendations, kind of all of the pieces do kind of need to fit together, so you can kind of see how we try to piece this all together. So bear with me a little bit, and then we'll return and open it up for conversation. So this first section, this would be at the beginning of the draft recommendation. Again, really just an introduction, describing why it is important to talk about multi-payer primary care payment reform, and a little bit of the evidence base around this. At the bottom of this slide, we note that in our last deliverable, we called for an increased investment in primary care by establishing a primary care spending target. As Dr. Altman noted, that primary care spending target was 15% or double, whichever is higher, within 5 years. And as part of that last recommendation, we also said that the increases in spending should be prioritized by payers and providers to support the adoption of innovative payment models that support the delivery of the 4 pillars of person-centered primary care, which we have discussed before. So this is really just an introduction to the recommendation. This next part of the recommendation is a section that summarizes the discussions that we've had at the 2 last task force meetings, reflecting the conversations we've had around the importance of needing to change payment, that just increasing investment alone will not deliver the results that we need, that this needs to be multi-payer alignment, that there needs to be a focus on reducing administrative burden as we do this. These 6 goals were ones that we had displayed on a slide at our last board meeting in January and had discussed. And so again, kind of repeating these core goals for the purposes of the payment reform. I'm not going to spend as much time on those 2, but happy to return to them. I think the next part of the slides is really the meat of the new recommendations here. So here is where we get into the 4 pieces of the recommendations. The first is that this task force would recommend that the Commonwealth enact policies that advance multi-payer primary care payment reform to achieve the goals that were stated previously here. And these would be the ways that we would recommend doing so. First, that the legislature should authorize the development of a aligned multi-payer advanced primary care payment model that would be available to all primary care practices in Massachusetts. And that primary care, the payment model should include key components such as a prospective capitated payment, that it should recognize enhanced care delivery capabilities and quality performance with enhanced payments, that it would include appropriate risk adjustment, including for patient social needs, and that it would establish aligned quality measures and reporting to promote administrative simplification for practices. So first, a statement that the legislature should authorize the development of this aligned advanced primary care payment model. Secondly, we have a section on payment model design considerations. That in the design of this advanced model and the component pieces of the model, there should be a balance of the goals of both standardization and flexibility, recognizing that not one model fits all payers and providers, and that there should be an incorporation of the following principles. An alignment of this advanced primary care model should align with the Mass Health Primary Care Subcapitation Program while allowing for appropriate adjustments. That the advanced primary care model should ensure meaningful multi-payer alignment on reporting requirements and parameters to decrease administrative burden, including quality measure reporting that should be focused and aligned in the model design. And we recommend in consultation with the newly developed statewide quality advisory committee. That the model should set appropriate standards for demonstrating enhanced care delivery capabilities for that purposes of that enhanced payment, while still allowing for payers and practices to innovate and adapt approaches as needed. We did talk a fair deal about the need for flexibility and adaptation for practices and how they might best put forward or develop their care teams or their individual practices. So balancing, again, kind of standardization and flexibility. That the advanced primary care model should be designed and implemented with the input of primary care providers from a range of settings, independent practices, pediatric practices, FQHCs, as well as health plans and Mass Health. And finally, that the advanced primary care model should reflect commercial payments that at a minimum meet levels indexed to public payer benchmarks to ensure fair pricing. Example is providers that commercial payments would meet at least a percentage to be determined of Medicare, or in the case of FQHCs, that the commercial payments would be at least as much as Mass Health. The next section talks about how that advanced primary care model would then be deployed in the market. So here, the recommendation would say that the legislature should require that that model, as developed by the previous two recommendations, would be required to be offered by all payers subject to state jurisdiction. This would be an offering. It would not be primary care practices would opt in and have the opportunity to. They would not be mandated to take this model. This would be an opportunity by them, but the plans would be required to offer a model that met the specifications of the advanced primary care model. This would be through plans regulated by the Division of Insurance, the Group Insurance Commission, and the executive office would also seek alignment through Mass Health. The second part of this recommendation, which I suspect we'll spend some time on, reflects a reality around the self-insured market. And here we, discuss that ideally we would like to see this model be offered and implemented in the entire commercial market. Here we describe and reflect the known limitation of our state law and regulation in the self-insured market. And here provide a recommendation that the state essentially use every tool at its disposal to encourage, promote the adoption of the advanced model within the self-insured market. And the state should continue to explore and consider any and all additional policy and financing options to extend the model to self-insured plans. The final piece of this particular section is the opportunity to also bring Medicare into this aligned payment model, and an encouragement to the state to pursue opportunities for perhaps Medicare demonstration programs that also align with the principles of the advanced primary care model that we would have developed, include very specifically that if the Medicare demonstration project had principles around prospective payment, enhanced payments, and support for team-based care models, which some of the Medicare demonstration models appear to have. And then finally, a section on monitoring and accountability. So having developed the model, having had a process for considerations of what going into that model, having then deployed that model out into the market, this last section would be tracking kind of the monitoring and accountability and impact of that model. So a couple of subsections here. One are, our plans implementing the model as required. A tracking of the uptake, so that we can understand both kind of across all of the different payers. Is this model being taken up by providers, specifically calling out the self-insured market here, and being able to track, are we making progress in that particular market, and perhaps directing the Health Policy Commission to continue to make policy recommendations to promote adoption. A common theme and then finally, two common themes that we've talked about over and over again, which cannot be understated and can always be repeated, that the primary care payments should be going to primary care practices, and that this monitoring accountability should follow that. And then finally, that the primary care spending should not increase overall healthcare expenditures or result in a net increase in health insurance premiums and cost sharing. That was a lot. I'll return to perhaps the beginning of this slide deck, and we can take each of these in turn and kind of bounce around depending. There are obviously interconnected pieces of this. Overall, this was an attempt to try to think about how we can promote an aligned payment model that will provide flexible, prospective, enhanced payments to primary care practices, that will enable care redesign and reduce administrative burden, and to do so in as much as the market as the state has that ability. So I will pause here, and we can open this up and be in conversation, and the secretary's gonna.
I'll be logistician, and David will pay attention to what you're actually saying. So we'll go with Wayne, Stephen.
Can I just say one
Yeah,
thing
please.
about, I just want to say that I think you said this, and I want to just reiterate it, that this set of recommendations has come from all of the conversations that we have had in this task force. So it's not like somebody walked out and said, I'm going to do a model. It's just gathering all of the stuff that you all have heard that we've put out. And so that's what's reflected in here. And I just wanted to make that clear.
Wayne, Stephen.
Okay, so thank you, David, for sharing those slides. I think that there's so much good in those slides. The Medicare demonstration program, if we get the first parts right, is a great idea, perhaps 34 months from now, when an opportunity may present itself. Aligning with Mass Health, who has already done so much of this work and kind of set the table for us, I think is a brilliant idea, and that we should be all on board with that. An advanced primary care model, as you outlined it, is exactly what we need to do with all the components. As Senator Friedman said, it's all the stuff we've been talking about for a long time, and that's really great. I would say that so much of the details you would not legislate because it's so in the weeds. And that would be for a primary care advisory body, which you referenced, but as a technical body. I think we would need a primary care advisory body, perhaps a technical body as a subcommittee within. I don't think we want two. We don't have to get in the weeds of that now, but so I'm in favor of all of those three things. When I started on this journey personally in 2018, the first person I went to meet with was John McDonough. And John said, well, this is all a great idea, doubling primary care spend, prospective monthly payment, all this is fantastic, but you're going to run into a brick wall called ERISA. And you're not going to be able to get past that brick wall. But we found a way to get past that brick wall in terms of including the self-insured folks. And the way you do that is we make one little tweak on your slide where you described a multi-payer implementation. We changed that to a single-payer implementation and a single payer for primary care, otherwise known as the Primary Care Stabilization Fund. And the last thing I'll say about this for now is that when, as a family physician, as a primary care physician, when we are at our best, we are addressing the root cause of what ails our patients. I will confess, as a medical profession, we don't do a good enough job in doing that, but when we're at our best, that's what we're doing. Well, as health policy folks, we should employ the exact same strategy, is addressing the root cause. And it turns out that health insurance plays a very important role in healthcare, but not in primary care. Insurance is for unexpected and catastrophic outcomes. Primary care is neither unexpected nor catastrophic. And so that is one of the root causes of what ails us. And this single payer for primary care addresses that. And I think we need to do the right thing.
Thank you, Wayne. And because this topic is more complex than usual, I'll be more generous. And we'll go with 3 minutes instead of 2 minutes. And so we'll go with Stephen, then Laura.
Thank you. I'm ready for 2:59. This is such an artful catalog of what we've been discussing. It's very difficult to do what the team has done for these slides. It's almost like a Gettysburg Address of elegance, I swear. One particular phrase on this slide, the first bullet point, is particularly artful, which is payment to primary care practices. And I'm going to build a little bit on Wayne in my limited time. So I'm coming in from the Boston Post Road, basically from the rural. I started 4 hours before the meeting. I got here in time. We have two of our independent practices are laying off workers from primary care. And they together cover over 60,000 patients in the rural. And this is at the same time that my local public school is now without a librarian or curriculum director because of an 18% increase that we budgeted for healthcare. This is a paradox that we were going to really have to wrestle with, and a generational movie illusion. But this reminds me of the Star Wars trash compactor. Like, we are in the trash compactor now. Things are unraveling now in ways that this planning may not be suitable into its time frame. So I think we need to think about tomorrow, and then we need to think about legislative passing. So to support Wayne's thoughts, my sense from the Milbank report recommendations are that they're thoughtful, but they definitely do more. Basically, they sort of turn existing systems up to 11, another movie reference. But I think we have structural problems that will not be solved by turning things up to 11. And just a quick quote from our neighbors across the pond, David Lloyd George was the Prime Minister of World War I. There are times when you need the courage to take a great leap. You can't cross a chasm in 2 steps. Indeed, that is dangerous. And we have a chasm. And in 2006, the Commonwealth made a statement, and for universal coverage, that was crossing a chasm in an important one step. And I think in order for our work to be successful, we must have some sort of common fund, primary care stabilization fund, because that phrase, payment to primary care practices, is real. And the fund is the only way, and a single payer is the only way to make sure that that phrase becomes a reality. So thank you very much.
Thank you, Stephen. So Laura, then Mark.
So I'll be brief. I think the definition of advanced primary care practice, I'm wondering if we could try to take a stab at that definition. It looks like from this that the legislature would be left to define that. And I'm wondering if this group should try to do that.
In terms of
what
the,
exactly it is. I think we're kind of struggling with, are we seeing advanced primary care practice the way others around the table are? So what would be the components that would qualify?
yeah, I think in terms of what are the specific enhanced care delivery capabilities that would enable a practice to receive enhanced payment. I think we broadly talk about that as a necessary component of the primary care model, and in the considerations section, talk about the need that there should be some standards for that. And while I think also talking about some, you can see this language on this slide on the last bullet. I think reflecting a little bit of the conversation that we had that I think there was some conversation that we'd had about not wanting to be so prescriptive in defining this is the only way you can get this care delivery enhanced payment, and perhaps not wanting to recreate the PCMH very specific checking boxes to get to the enhanced payment. So yes, this recommendation does not define exactly how that would happen, but it does say that this necessarily should be part of the model, and I think defers a little bit to the development in terms of what exactly that would look like, and more as a principle to say it should be included. The payment should be helping to enable practices to enhance their capabilities without, in this recommendation, being very specific about saying you can only get the enhanced payment if you do a clinical pharmacist, so to speak. I don't know if that's what you're suggesting.
I think to put a pin in this discussion, I think for the MAP member plans, we want to see something different. We want to see some transformation. And so I think that's the key here. And as we talk about advanced primary care models, I think we're just not clear exactly what that is. So we're all in on, wanting to invest in primary care. We just want to ensure that things are going to be better for patients.
Thank you, Laura. Mark, then David.
I just have a few points. Lest anybody think all the health plans think alike, we don't. I'm actually going to argue strenuously against linking payment to structural capabilities of primary care practices. Every time this has been tried before, it's failed, unfortunately, and with really good intentions in many states, federal, you name it, it has not worked. And the idea here is, I love the idea of enabling practices to use enhanced payments to make structural, capability investments that are, best for that practice, its staffing, and the community it serves. But as soon as you say you don't get the payment unless you do those things, and then spend the money, and there's real money spent on this to demonstrate you've done these things, that's where things really get off the rails, unfortunately. Just give the money. And then say we want to see certain outcomes, and we'll, pay for that, not the actual structure, because we don't know better than the practices what to spend the money on, fundamentally. But we do know how to measure the outcomes, and that's what we should be focusing on. And that brings me to the question about the quality measures on the advanced primary care payment model. I just want to make sure we don't have multiple competing measure alignment bodies. Right now, the state has the SQUAC, which is brand new, has mandatory measure set. That's the right place to have those discussions for this model and all others. And I think maybe the way to meet the intent here is to think about modifying the composition of the SQUAC. If we want more primary care folks on there, you can always do that, but just don't have multiple coordination bodies that are not coordinated with each other. That will undermine, I think, the purpose here of trying to reduce administrative burden and focus on what's most important for patients and for health plan members. On the point about appropriate risk adjustment, I think we should just define what appropriate means here. I've done a lot of work on risk adjustment in my day job and my prior research jobs, and it's very easy with good intentions when you start throwing in social needs to have a risk adjustment model that unintentionally perpetuates or even worsens disparities and inequities in funding streams. So just put on there what appropriate means is it can't do that. It would be a definition of inappropriate for it to worsen inequities. That's all I have. Thanks.
Just to thank you, Dr. Freeberg. I think on just maybe on both Laura's point and your point on kind of the enhanced payment. I think there was an attempt in this language try to reflect your concerns around not being so dogmatic in the structural, you have to do this to get paid for this in how we tried to structure some of this language. So if you have ideas about if we didn't quite get that balance right.
I would just say provide all kinds of assistance and recommendations on what to invest in, but don't link it to enhanced payment.
And the in consultation with the squawk was,
Squawk is the separate issue. That's not paying for structure. That's paying.
Yeah, no, I was just saying that was an attempt to try to not have to try to bring in the alignment with the existing.
That could be made more explicit. Maybe.
Okay. Yes. Thank you.
So we currently have David and Barbara.
Great, thank you. So I think the one area in my mind that is really lacking as great as like it brings together all the things we've been discussing in a really nice way is just the transition, right? So to like Wayne's point, like it's great to get the payment and I'm not going to invest the dollars up front and hire up all these people and bring in all these resources. So I think there needs to be a little bit more explicit commitment to how to make that transition happen and lay some of that out. What is the commitment? What is the what are ways that we are supporting practices? If there's no additional dollars in investment, that's going to be really hard to do upfront to make that transition happen. And to your point, Mark, like the outcomes part that we really want to see, you just don't see for quite some time. And so to really know that you're, making that investment and seeing those outcomes, it's going to take, again, a commitment from the state to be able to fund and make that transition for practices. One other point, just going back to the healthcare affordability working group related to this, I know a lot of details need to be worked out. I assume that legislators will look to the healthcare affordability working group and others to help further define and give input. I don't know how well represented primary care is on that working group. I don't know all the members on it, but it's a concern when we have a work group here that is really well established with primary care representation. And I don't know that that is the same that you're going to get from that working group.
Just a quick response. I think it's a great point around transition and as I think linking this, in my mind is linked to the increase with the spending target, right? Like we're doubling the share of increased spending on primary care at the same time that we're, linking this with this new payment model. But I'd love to think with you about maybe there's some additional language we could consider about what happens in that kind of transitional period and are there some considerations or principle that we might want to articulate around expectations of what that might look like. So thank you for the comment.
Barbara S., then Suzanne, then Christina.
Thank you. I think we all are very, very supportive of all of these recommendations. And I think we also have to understand why capitation failed and has failed us, because it really has. For those of us who've been involved in capitation, I look at some of the people around the room, it has failed miserably. We started doing capitation in the 90s, and it has not brought the long-term innovation and changes. And why is that? Well, one of the problems was the structure is that as you did better, your payments dropped so that you couldn't eventually survive. Literally, you could not survive. So you ended up laying off people and closing down programs. We need to be sure that that doesn't happen. We need to understand that when most of primary care is employed by for-profit groups and academic medical centers where their goals are not the same, I would like to see bold recommendations that say one of two things or three things. One that says primary care contracts must be done out of separately. You may not be able tomorrow or in the next couple of years to take primary care out of the academic or for-profit organizations, but you can certainly contract as separate entities for primary care and put limits on how much goes to overhead, not decrease payments going forward. Understand that the benefits will take 3-4 years So prospective payments. And eventually, I think we need to have as a goal and investigate what would it take to transition to a model where no for-profit and no academic medical center would own and employ primary care. And then we have to come up with what kind of systems do they need, because we want to encourage private practices. We want to make sure that our federally funded health centers are able to survive and provide the critical care that is needed, so that we can not only have primary care as an employed model. Thank you.
Thank you, Barbara. Do you need to answer or we move on? Okay. Suzanne, Christina, then Renee.
Thank you. Just want to express appreciation for all this work and being able to take all of our comments into this really great recommendation here. Just a few points. One, I just want to echo that alignment is good not only for providers, but for patients, especially if we're thinking about what standard of care do we want to provide? How do we want to increase that standard of care? Another piece I want to just talk about is I think Barbara just alluded to this, the fair payments and how they're important. And I like the way that we're thinking about benchmarking as opposed to looking at how historically different providers have been paid, which build in inequities, especially for community health centers and independent practices. And as to patient experience and outcomes, I think we can build off a lot of what we have in existence, especially Barbara and MHQP's great work around the patient experience piece. And that goes to not also reinventing the wheel around some of the other pieces around developing a framework that we can work from, including the Mass Health Primary Care Subcapitation Program and what we're learning from that from practices. And last, I just want to say, I'm very interested in what we all what you came up with as far as a middle ground around getting at self-insured plans and, trying to incentivize the third-party administrators to offer this to self-insured plans as a way, and it could even be like a runway to maybe getting to another place of thinking about paying primary care even more differently in the future. But I think it's a good initial goal to really get to how do we get to these self-insured plans in a way that the state already has authority to do. And we've seen it done in some other places as well. So I just want to appreciate that of thinking about creatively about that piece. And I think that's mostly what I wanted to say. Thank you.
Thank you, Christina, Renee, then Barbara R.
Yeah. Thank you. The first thing I wanted to say, I'm going to burn into my time, but I did want to just say thank you for putting this together and for bringing it today. It's, you all know the expression, don't let perfect be the enemy of the good. Like this goes so far. Like it's so thoughtful. And there's so many things to not feel good about right now. And to be in this room and for me to feel good about this progress and this intent is just like a moment to sit and enjoy about what is possible. And I just want you to know how appreciative I feel. I have some questions, and this is some of my own lack of subject matter expertise. So here's a question. On ERISA, if there are provider requirements, so if the state says you provider groups, you primary care practices, the state has no requirements for primary care, and here they are. And we're going to regulate you and or require you primary care providers to organize in this manner, to get paid in this manner, to have these quality measures, et cetera. Can ERISA leapfrog that and say, no, we're an ERISA plan provider, you can't comply with state requirements? And I can just put a pin in that question or not, whatever is your pleasure.
I think without getting into the details, the answer is, even though they may not want to do it just because of in the contract negotiation, right? But technically they could say, no, we're not paying for that.
Okay, even though it's regulated.
And that's 2.1 million people in our healthcare system.
They are not required to follow any of our mandates. ERISA plans. So our insurers, for fully insured,
They have a whole set of requirements that they're required to follow. For an ERISA plan, they are not required to follow any of those. They
Okay.
can and often do, but they are not required. We have no control over their.
Thank you, thank you. We're self-insured. We have an insurance captive. I know we would willingly participate. That's a sample of one. I wonder, I do wonder if the carriers may have a gut or a process to get a general understanding for what percent might willingly be a yes for a new program. On quality measures, maybe this is too specific. I was curious if we could say within moving to more standardization of quality measures, can we commit to electronic clinical quality measures, ECQM? I see that the sort of looking at things for administrative simplification has been moved into number 7. And just want to make sure that in doing that, which is totally cool, can we ensure that because of the language on statutory deliverable number 7, that we're not creating any narrowing because we keep putting more things in there. So that was just, wanted to ask you that. On the Mass Health Primary Care subcapitation program, in addition to the capitation itself, and in addition to the model of care, there's also quality measures that could be replicated. There's a risk adjustment methodology that could be replicated. There is language in there about requiring the monies to go directly to primary care practices. As somebody who receives those monies, we don't even record it as revenue as accounting treatment. We treat it just as a pass-through. So there may be more elements of the Mass Health Primary Care subcapitation that can be incorporated as part of what is being replicated. And then I will just that the penalties for non-compliance, which is in this last section, I would like to see it with a little bit more teeth on, what happens, real consequences for non-compliance. And then lastly, Barbara, I thought you might just mic drop and walk out after that. It was so brilliant. Thank you. And it, given the other comments around wanting a primary care trust, again, to not let perfect be the enemy of the good or to make it perfectly imperfect, could Barbara's suggestion be a way to thread the needle on not going all the way to the trust, but getting at one of the things which may be a critical path impediment? Thank you.
Thank you, Christina. So let me interrupt since we have 4 more, Renee, Barbara R, Judith, and then Laura. Let me just interrupt to see. So quick question, number 1, Ryan, capitation has come up several times and subcapitation, most notably when Barbara said it was a complete failure. And I know you just published something last week that was the opposite of a complete failure. So I was wondering if you could take a few moments to talk to us about what the Mass Health subcap program has been. And then Christina just mentioned a few of some other topics that are embedded in there. And if you could just give the task force some clarity on that. And then after that, I'll ask Mark or Barbara to comment on the feasibility of having purely digital measures, quality measures. I know that topic has been hot and heavy at the squawk, so.
Thanks, everybody. Morning, good to see everybody. So I think, Barbara, your comments and points are well taken. I think we should distinguish between eras or capitation in the era of the 1990s and honestly, even before then, which I would completely agree, failed miserably. And honestly, much of the challenges and the structural deficits in our current healthcare system were actually, the foundation was laid 30 and 50 years ago. Renee has written eloquently on the Rock and how that also played into some failures of capitation. And we have learned a lot. And so I think we would humbly suggest not to simplify the term capitation into what we saw in the 90s to what it can be today and moving forward. And I think a part of the goal of our design of the Mass Health model was to say, yeah, it did fail miserably in the 90s. And what did we learn there? And we're a bunch of smart people around the table. And honestly, we're Massachusetts. And so that's kind of our goal is to learn from failures of the past and how do we incorporate those learnings as we move forward. And I think one of the key questions that capitation of the 90s really missed was accountability on the payer to actually guarantee that dollars flow and result in the outcomes that we want to see. And if we look at the Mass Health model in particular, just as a foil, it's important to note that the primary care capitation program does not exist on its own. It exists within the context of an accountable care organization. And we did that very intentionally because every ACO is accountable to quality measures that hold them, I would say, guard against intentionally much of the travails of the 90s, which was that you can, be paying a capitation and doctors can go out and play golf because they are not accountable to actually delivering any services. That is what we saw in capitation models of earlier years. However, when you link a capitation payment with an accountability for a quality measurement slate, as well as, importantly, thank you, Barbara Rabson and her team, measuring the member experience and what patients actually receive at the end of the day. That kind of three-legged stool is a very important foundation and structure that hopefully, I think we are optimistic, will lead to a much different result and outcome for patients and for providers from a capitation system that is not what it looked like in the 90s. And so I think as we are thinking about recommendations for the task force and for ultimately what other payers in the Commonwealth and beyond might look at, we shouldn't be thinking of capitation as solely about a payment mechanism, but within which construct and context that exists. And if you set the right parameters around a capitation payment, I think we can be optimistic that it will result in different outcomes than we saw.
Thank you, Ryan. Mark or Barbara, which one would like to take that purely digital quality measure?
Yeah, I'll just say it's something being actively discussed in the squawk and the related alphabet soup of bodies.
Thank you.
I would just say it's not here yet. I mean, there are some challenges with the measures that we couldn't move to it today because it wouldn't work. We can hire them, but there's a transition.
Thank you. So now we have Renee, then Barbara R. Yes, she's after Barbara R.
So one of the things I want to say is, number one, this is such a great conversation. We should just all hang out. So on the payment intended for primary care, ultimately Bennett's primary care practice, we could do this the Massachusetts way and make like a massive bureaucracy that watches out for this, or we could do what like Laura's talking about and do something new and different and create a system that actually is a self-reinforcing system. And that self-reinforcing system is making it so that it is easy to have an independent practice. It is incredibly low threshold. A low threshold to enter independent practice. And I should be, as an FQHC CMO, I should be able to pay my primary care providers the same as MGB pays them. If you do those two things, create a low threshold for independent practice and get rid of the disproportionate payments that bigger systems get, folks will be able to, vote with their feet. Right now, they cannot vote with their feet. I mean, it would be going a long way to say they're indentured servants, but the fact is when I see my younger docs getting to the point where their kids are like looking to go to college, I'm like, so BI or MGB? And they're like, BI. Because they can't send those kids off with what I'm paying. So the two big things that I would say is, yeah, you could set up a massive system with blockchain so that you could trace every dollar and make sure it goes into primary care. Or you could say, let's make it a low threshold to enter independent practice. Let's make it a low threshold to deliver primary care. And let's remove the asymmetry in what people are getting paid for primary care for doing the same job. And the way that I really see that is reduce the cost of delivering care, reduce the complexity of delivering care. And we keep talking about, multi-payer, single payer, big stabilization funds, all this. I really believe that what the PC4U adds is the ability to say, It's a multi-payer, single fund that provides common health for the Commonwealth. That's what we're looking for. Everybody in the state gets great care. Everybody in the state gets access to primary care. We lower the bad debt of the hospitals. We lower the bankruptcy of the patients. And everyone knows where to go when they have a stabbing pain in their ear because they have a trusted contact. We have the ability to do that.
Thank you, Renee. Barbara R., then Judith, then Laura.
First, I want to echo everybody's gratitude for this great work. So thanks, team, and thanks everybody here for this wonderful dialogue. So I want to go back to, I know, David, you didn't want to talk about this, but the summary of the task force deliverables, the first one, it says improve patient access and experience, which I think is really sort of what Renee was saying is why we're all here. And what worries me a little bit about this is the words that follow that. It says enable provider flexibility to provide right care, right time, right place. Because providers don't really have that flexibility. And part of that goes to, the systems that clinicians work for. And the idea that if you don't refer to certain places, you're going to be penalized for leakage. You're supposed to refer within your system. There's a lot of oversight about how this is managed, and it's not provider flexibility. It's really bigger than that. And I think it goes into the discussion about, who do we want our primary care practices to be owned by? And one of the things that I think we need to track, and I'd like to make a formal recommendation that this group recommends MHQP and CHIA on the primary care dashboard, track practice ownership, whether it be for-profit, whether it be academic owned, whether it be concierge, whether it be direct primary care. We don't have that information in the state at the practice level. And so I think that's a really important component for us to understand what's going on. And if we say, okay, we want to recommend that, we move towards independent practices. Well, where are people now? And what would that path look like? Because depending on what infrastructure you have, it would be different. And so, to create this path forward. And I'll just end by saying, the things that we like we talk about value-based care and how, it's more accountable and not all this stuff. It's value-based care and the hidden infrastructure required to deliver it, which drove people to work for big systems and private equity because they didn't have the money for the system. My sister worked at an independent physician group in Madison, Wisconsin, and they felt we've got to move to value-based care. We need the computer and other infrastructure, measurement, so all the stuff. And we data warehouses, and we don't have the capital. So we put ourselves up for sale. The national system bought it, and then over time just dismantled. I mean, just piece by piece, it's a shell of what it was. But it was driven by this, okay, these are the requirements that you have to deliver care and get paid for it in this world. So I think it's important to acknowledge that too.
Thanks, Barbara. Judith, Laura, then Wayne, then Brenda.
Yes, thank you. So I'm a bit concerned that what I'm about to say might be incredibly unpopular in this room, but I'll try it. And that is that I'm very devoted to transformation. I always have been, and I expect always will be. I'm reluctant or concerned about the idea of removing a type of practice for primary care clinicians, physicians, practitioners in Massachusetts. In particular, I'll speak for the academic practices, which I've heard many people say, "Oh my goodness," and concerns about them, and I'm sure those are very well founded. But I also know, but personally, I have members from our organization as well. And we have some people in this room who I won't identify, but some people in this room who work for these large entities. I'm not now talking about the for-profits. I'm distinguishing importantly between for-profits and the major healthcare systems, which and in that I'm using more than just the two with 4-letter acronyms. I work, by the way, for one of those. I work for BILH, and have many friends who work for MGB, but I'm not restricting my thoughts around this to those two excellent organizations, but also to those across the state that are medical centers, Tufts Bay State, et cetera, BMC, et cetera. There are many physicians practicing primary care who practice a little bit of their time, at one of those. A little bit of their time does a lot of good for the patients that they care for. And their career goals are maybe to do research or administration or whatever in the rest of their time. And if we were to say, oh boy, this is bad, you got to get a private practice within a certain number of years, you got to go into a private practice. Realistically, you can't really practice sort of half a day a week by yourself. So what's going to happen to your patients the rest of the time? Massachusetts is renowned for having leaders in so many aspects of medicine, including primary care research and exploration that is very important to us, sometimes rises to people being at national levels, certainly highly regarded across the country and often around the world. So I would like to not have an outcome of our work here be that a goal is get rid of that, and I understand that there are great concerns about the being employed and about employers. Some people have more concerns than others, but I don't think we need to prevent that in order to save primary care. I'm not speaking now about the for-profit entities in VC. That's a totally separate and important issue and might need a whole different set of rules. And I don't feel that I have really the standing and the personal experience to speak to that. But I have plenty of experience with what I just talked about. And I haven't heard that we think that those doctors that they are bad doctors. I'm not hearing that we think that there's a quality concern or something like that. If there were, of course, totally different thing. But it's not. It's
30 seconds.
So I also will use as a couple of examples, and this might be might not be what we want, but out of an example of the value of having a primary care practice, right there that is employed by you is that when COVID arrives, for example, let's hope we never experience that again. But when COVID arrives, the next day, those of us who were practicing primary care can be in the hospital, and we're in the hospital providing care. And you can't expect doctors that you don't employ to come running for that. You can hope, but you can't, expect it. And pretty much across the state, probably entirely across the state, that was true. It was the employed individuals. Hopefully that was an N of one. Doesn't matter. Never going to happen again. But that as an example, also 7 days a week providing urgent care. One doctor practicing by herself can't do every night and all day, both weekends, right? So both days, every weekend. Having some people that are in employed situations can be beneficial for all of us. Thank you.
Thank you. Laura, Wayne, Brenda, and Senator Friedman.
I'll be brief. To pick up on Barbara's point, we have been exploring in a subgroup at MAP whether we could have separate contracts for primary care within systems. And so it looks like that's something that we can continue to look at, talk to the legislature about, talk to David about. But I did get a positive response from our subgroup that is something that we can do, so long as we're not increasing overall costs. So that might be a way to get to that, some of that transparency concern that we had about whether funds flow would make it actually to primary care. So I want to put that on the table. And then the alignment with Mass Health, thank you, because I think I'm reading in this some flexibility for the commercial market, since the commercial market isn't identical to Mass Health. So thank you for that, and we can do more work on that as well, what it would need to look like.
Thank you.
Okay.
Great. Thank you, Laura. Did you see that, Wayne? That was like 45 seconds. Yeah.
It is our second turn.
Okay, 3 points in 3 minutes, Kiami. We've heard about capitation failing, patient-centered medical home failing, and paying for the primary care transformation and the transformers failing. And I think we're talking about apples and oranges because rarely in large scale has capitation been associated with doubling of primary care investment and a prospective monthly payment. Well, it is a prospective monthly payment. And so also, when something is capitated, once it gets down to the physician level, it's no longer capitated. It's capitated at the ACO level, but doctors in a practice are still functioning on a fee-for-service chassis. So psychologically, it is not a capitation, even though it is capitation, okay? Russ Phillips and the Center for Primary Care did a study asking the question, what percentage of patients need to be purely, truly capitated to start to develop that capitation mindset that we want clinicians to develop? It was 70%, okay? And the ones where it's not really capitation, even though it is on the ACO level, doesn't count on that 70%, okay? If you are in the Mass Health ACO, that is pure capitation. That counts as pure capitation, but the other stuff doesn't count. So we've never, what we're talking, patient-centered medical home, they didn't really give any significant extra money. There's just all these things you had to do, but at the same budget. So we've never really tried what we're talking about has failed. What we're talking about on these slides is trying something for the first time that could be landmark, historical, and a national model. Second point, this is a very quick one. I think your slides referenced this, David, but we need to have specific language in legislation that says that a minimum of 95% of the money designated for primary care goes to primary care, for the patients of primary care. And I'm pretty sure all three bills have that language in them. I'm also pretty sure all three bills have language around the primary care transformers. Laura talked about transformation. We call them the transformers in PC4U. And all three bills have some specifics that you're looking for in that language.
30 seconds.
Finally, last point. We've talked about incentivizing self-insured plans to double primary care investment. And it's a nice thought in a dream world, but we had a business summit about a year ago to talk about this and ask everybody to look in their crystal ball and see if we passed primary care legislation without with the ERISA barrier for these 2.1 million people, what would those folks do? And John Hurst was at this summit and other business leaders were at this summit, and it was pretty clear they would choose not to participate, the majority of them. I'm glad we've got one with Christina Severin, but most would not participate. And that's what makes multiplayer versus single payer an important consideration. Thanks.
Thanks. Brenda, then Senator Friedman.
Thank you. I would say, this looks really great, and it looks like a model that could be really sustainable for both our practices and for our pediatricians. Just looking at simple things, well, not simple, but fair pricing. Most pediatric practices that try to be independent still have to connect to a larger system. In the Boston area, it's Boston Children's or MGB in order to have an alliance, just because for reimbursement. I think coming up with a system also where it's less of that fee for service that Wayne's talking about allows our workforce to be less burnt out, so that they're not always having that pressure to see 25 patients a day, which I agree, having worked in that system where you have capitated and then also fee for service patients. That doesn't get down to the individual level. But I do think if it is more sustainable, there aren't physicians and pediatricians are able to do some of the things that are not, just for those fee-for-service things. They can do the step one, which we have, which is improve patient access and experience, so that they are able to make that phone call to the family, that it's not necessarily your nurse. The nurse can do it, but the nurse is asking the doctor, the family knows the doctor or the clinician. And I think some of those very simple things can keep people actually out of the emergency room if we have the ability and to take care of our patients the way we want to. And I see a lot of that from what's here, if it works.
Thank you.
Oh, thank you. This has been incredibly informative. Where the legislature, the Senate is trying to ready a primary care bill, and we're trying to stay in line with the primary care task force. And so having this conversation is really critical. I want to just comment on a few things. If you get a lot of lawyers in the room, if you get 6 lawyers in the room, you'll get 10 to 12 opinions. It is far, far, far from uncertain that the federal government would allow us to do an assessment, which is what it would be called, on ERISA plans. It is far from uncertain. In fact, we had a conversation with a lawyer that Wayne put us in touch with that said, hey, every state can build their own budget and they can decide how they're going to spend their money. And we thought this is okay. You know, this is just, we're going to do an assessment just put an assessment on different companies. We went off and did a little deep dive. And in fact, what the rules are in Medicaid is if you apply a tax to a entity that is fundamentally doing healthcare, then has a chunk of money in healthcare, that would be considered a tax. So how you get around assessing everybody becomes a real challenge. And I will tell you that under this government, if we do a single payer, we will be spending years in litigation and we will not move forward. It is not what I want. It's not how I want the whole system to work, but I'm just giving you the reality. There's bold and there's bold. And there's bold with a plan and there's bold with, hey, let's just break down all the rules and see what happens, or, you know, go after the fight. So I am very, very concerned about that. We have spent a number of time talking to different providers and providers in systems. And one of the things that we keep hearing is what the big issue for many people that we talk to about becoming independent is the electronic health records.
Yeah.
Is that so? I would argue that if we're going to do something, we don't want to be prescriptive, but there may be something that we want to look at that actually directly talks about infrastructure. It's not, we're going to give you money, and if you do more of this, then you get more money. It's to fundamentally start this, we do need something that allows people to make that transition, if that's what they want to do. I think the good piece about what I'm hearing about, Barbara, what you talked about, to us, it's not whether we allow a primary care practice to be part of a system. I would like to disallow all private equity, by the way, and we will keep fighting that fight. And haven't gotten there yet, but we'll keep fighting it. But I think the issue is getting the money to the primary care practice wherever they are, and then being able to track that money goes to that practice, that a system can't claw it back. They can't take 30% of it. They can't muck around with, okay, we'll give you the money, but then we're going to charge you extra to use our systems. That's, I think, is what the real kind of nut of this is, because regardless of where you are or what you're doing, whether you want to be part of a system and you don't, and there's doctors all over the place. I mean, if we said you can't be part of a system, we'd get all sorts of people calling us up and saying, how dare you write legislation that doesn't let us be part of it. So remember, there's all these, but it's really being very clear about where the money goes and what and how much of it stays in it. And that's what Mass Health has done so well, right? That's how Mass Health has looked at that piece. And we should look at how we model that in a commercial space. So that sort of was my reaction to low threshold for independent practices. I think paying the same becomes clearer if we have a model where there's direct negotiation between primary care and the payers, and you get to see that. You got to work it out. I think the other incredibly important thing is that whatever we do, and I think it's been alluded to here, is it is across the board. Blue Cross is 0.32,
United Healthcare all have the same plan. Because if you start to let people navigate differently from that, you're all going to be back into your administrative burden, right? It's just, it'll happen because that's just the nature of the beast. And then finally, and we're going to do this we're doing this as we shore up our primary care model. We want to start talking about adult primary care and pediatric primary care because they are not the same. And so anything that happens in that space needs to make sure that we are taking care of both of those primary care systems. And we are concerned, and especially concerned from being part of this group, that we don't lose that difference. It's not huge, but it's profound. So I think those are the things that from what I've all heard from you, and this is so invaluable. Last thing I want to say is just remember when we're putting all this together, you all have an opinion that I 99% agree with, but then there's the rest of the world, and the rest of the world's going to come screaming in. And I don't want that to stop us from being bold or doing the best thing, but I just want you to know that that's a reality that we'll be dealing with moving forward. So thank you for this. Thank you for putting this together. It's amazing. And thank you for all of the incredible input.
Thank you, Senator. And given where we are in time, I think I'll let David sort of guide us in terms of what we want to do for the last 10 minutes and where we want to go.
Should we dive into deliverable 5 and
Definitely.
Unfortunately, no. Thank you, Senator. And I think it's really encouraging to see your thinking evolve and how these conversations are connecting to your thought process as you're pulling together this legislation. I think it's exciting to hear that you're considering moving some of that forward. This has been a really great conversation as always, and I'm just grateful as always for your contributions and for your consideration and the information that we put together here today. I do think that there is, as always, much more consensus than disagreements in all of these principles. As I think through this particular recommendation, we talked about at the beginning here the increased level of difficulty in the Triple Lutz Olympics or the Gettysburg Address. But I keep coming back and I'm heartened by when we talk about what is our ultimate goals, what are we striving towards, what is our true North Star. I still feel like we have so much in common in terms of what that is. So I still want to try to continue to move us forward and to continue the momentum that we've built here in terms of continuing to tick through these deliverables. And while still reflecting and want these deliverables to reflect in places where we don't necessarily have consensus and where there are areas where there are different approaches that different members may reflect and recommend. So I guess as we have done in perhaps the past couple of deliverables, I would suggest that we take back and reflect on this conversation today and the suggestions that you've provided, provide back out to this group, kind of a written draft of what has been included here, but then amended based on this conversation. Provide members an opportunity to then come back with further comments and thoughts. And if we feel that as co-chairs we've kind of gotten to a great place, hopefully maybe we could post something by the March 15th date. So that would be the goal. And as always, if you have questions, thoughts, concerns, or comments, you can reach either of us as co-chairs. As always, if you have other ideas, thoughts, and resources, please reach out to our incredible staff, Kelsey and Millie. And I will say on the deliverable 5, assessing health plan design and changes that may increase access to primary care, open to ideas. So think about that as well. We have been thinking about that and can come prepared. We are want to continue to meet, but we are reaching the end, at least, of our legislative timeline. But I think we still have some much work to do. And I think as I've been reflecting on where does our work come to, I do think there's an opportunity for some summative work in terms of pulling all of these conversations together in towards a more comprehensive, not just each of these individual deliverables, but a kind of a comprehensive discussion of what this task force has really discussed over time. But here you can see our upcoming meetings. The workforce work group is very hard at work as they have a very important task to really focus on the administrative burden and the workforce recommendations. So you'll see we've got a couple of meetings planned virtually for them. And we would plan to be back virtually with this full task force in a little over a month. So any questions, comments, and thoughts before we close out today's meeting? Yeah.
I just had one question relative to the time frame on the impact of healthcare, health plan design on access and what we're thinking about there, because I know it was originally slated for March 15th. Clearly, that's not going to happen. So is that the topic of discussion for the next meeting, and then we'll just kind of go from there? Okay.
Yeah, that's my thinking.
So I just wanted to thank people for their participations, and I've been remiss not to acknowledge my Quaker training and to thank all those who don't speak, because just like writers need readers, speakers need listeners. So thank you for everyone for their contribution today. I think as Senator Friedman summarized, these are very exciting times. And I think she sort of implied that, once your work on this task force sort of comes to its natural close, there's still lots of sausage to be made and lots of opportunities for involvement on your side. So we wanted to thank you for this great conversation on really complex topics, and I'm still remain quite hopeful that Massachusetts will be able to do some remarkable things in the coming weeks or months. Thank you.